Let's continue our core concept talk. So today's topic is hemophilia A. Hemophilia A is a X-linked recessive disorder which is quite frequently tested for board exams. It is less likely that you would be tested for its pathophysiology, but you will be definitely tested for the surgical management related points. So we have four scenarios. So what is the best treatment option for hemophilia A? That is the factor VIII concentrate. But if there is some definition that defines that there are certain levels, which I will talk about later, and we have the mild sort of disease, then desmopressin can be the answer. But if these MCQ statement shows that the patient is having severe hemophilia A, then along with desmopressin, you have to select aminocaproic acid as the part of the management. But there could be another scenario that can say that there is an urgent surgery needed or there is an elective surgery that is required for a hemophilia A patient, and you can neither find factor VIII nor you can find any levels that defines it as mild, moderate or severe. Then you will go in that scenario for cryoprecipitate. So these four scenarios are very important, especially for the MCQs. So let's get a short overview of the hemophilia A. So hemophilia is a genetic bleeding disorder caused by a deficiency of factor VIII. So in regard to the surgery, preoperative management and perioperative hemostasis are the key points to know about. Hemophilia is an X-linked recessive problem. However, its severity depends upon the levels. For the severe disease, the levels should be less than 1%, which is frequent spontaneous bleeds. Moderate is defined with the levels between 1 to 5%, and there is going to be a mild disease in which the levels are going to be between 5 to 40%. So, in terms of surgery, what are our goals and what should we be thinking? So to prevent excessive bleeding, we have to maintain adequate factor VIII levels before, during and after the surgery. And we have to use meticulous technique during surgery to prevent hemostasis, and we have to avoid any medication that can further impair the platelet function in such a patient. So let's talk about the surgical management. The preoperative planning includes to assess for the baseline factor VIII levels and coordinate with the hematology team to guide with the perioperative factor VIII replacement plan. Further, we have to screen for other bleeding risk factors, as the patient can have liver disease or an added platelet dysfunction. So how are we going to replace factor VIII before and after the surgery? So our aim is to keep the factor VIII levels to 100%, that is nearly normal. So for the preoperative, we have target value of 80 to 100%, and this should be maintained 1 hour before the surgery. In the first 3 days postoperatively, 60 to 100% value of the factor VIII is required, whereas in the 4th to 7th post-op day, 40 to 60% value has to be achieved. Now this value is a bit less, but it is required for wound healing. But for minor surgeries, 30 to 50% of normal factor VIII levels may be sufficient to perform the surgery. So how are we going to replace factor VIII? So there is a mechanism to understand its dosage. So 1 international unit per kg of factor VIII is going to increase the plasma level by 2%. So to achieve 100% factor VIII levels, we have to give 50 international units per kg to achieve our value. So for preoperative major surgery, 50 international units per kg of factor VIII is the answer, or this could also be used for the normal ward rounds to answer during VIVA. So for postoperative maintenance, 25 to 40 international units per kg every 12 hours is required. So in addition to this management, what are our additional options? we can use tranexamic acid or aminocaproic acid, which I have explained that they will be required for severe hemophilia A cases in which there is value less than 1%, then desmopressin along with aminocaproic acid can be used. And specifically, we have to avoid use of aspirin and NSAIDs. Additionally, we have desmopressin. Now, desmopressin can alone be only used for the mild hemophilia A cases because it is going to increase a small amount of factor VIII in our blood, in the patient's blood. So, what are the special considerations? We have to make sure that the surgery time is minimized, the surgery technique is good, and good hemostasis is secure. And postoperatively, we have to look for the patient in our ward to avoid the development of a postoperative hematoma and to look for any wound side oozing or joint bleeding. So, how are we going to monitor? Factor VIII levels, APTT, which is because the factor VIII is part of the implicit pathway, and for implicit pathway, the test which we use is the APTT. So, both are linked. Then we are going to use hemoglobin because such patients are likely to develop any blood transfusion reaction, or there could be a decrease in hemoglobin because of excessive bleeding. So, and we have to look for the clinical signs of bleeding as well. So, I hope I have answered and highlighted all the important facts clinically to know about the hemophilia A. So, thank you very much for listening to this lecture. So, do subscribe so that I can make more videos like this.